You can run a 10K, feel perfectly fine, and still carry dangerous plaque inside your coronary arteries. That is not a rare exception. It is one of the main reasons heart disease can stay hidden for years. The body is built to adapt. That is usually a strength, but in the arteries, adaptation can become a trap. A person can feel healthy while the disease keeps building underneath, out of sight, out of mind, and out of the reach of ordinary symptoms. That is what makes this so dangerous. Most people think a heart attack should feel obvious long before it becomes serious. In reality, silent ischemia exists, and many people have reduced blood flow without knowing it. Some people only discover the problem after the system has already crossed a line. By the end of this, you'll understand the mechanism, why it matters, and why so many people misunderstand what's really happening. Your heart is not a passive pump. It is one of the hardest working muscles in the body, and it depends on the coronary arteries for a constant stream of oxygen-rich blood. If those arteries become damaged, the heart may keep functioning for a while, but the risk does not disappear, it accumulates. What most people never see is the way the artery wall changes over time. Plaque does not always behave like a plug in a pipe. In many cases, the vessel wall can remodel outward, preserving the inside opening while disease grows in the wall itself. That means blood flow can look deceptively normal, while plaque continues to expand. Think of a road that stays open because the shoulder keeps expanding around the problem. Traffic still moves. Drivers think everything is fine. But the damage is still there, and the structure beneath the road is getting worse. That is what makes the silence so misleading. The danger is not always in how blocked the artery looks today. The danger is in how unstable the plaque may become tomorrow. That instability is the real turning point. A plaque can sit quietly for years, then suddenly rupture and trigger a clot. The body sees the rupture like an injury, so platelets rush in to seal it. That response is helpful if you cut your finger. Inside a coronary artery, it can be catastrophic. A person can go from feeling normal to feeling very wrong in a short time, not because the disease appeared out of nowhere, because the disease had been there already, hidden in plain sight. The event was sudden. The process was not. That is why a healthy-looking person can still be carrying serious risk. The question is not just whether your heart looks strong. The question is what is happening inside the artery wall while everything still looks calm. And that is where the story gets more unsettling, because the body can hide the problem so well that even the first warning may arrive too late. The real danger is not only that plaque exists, it is that plaque can stay quiet until it becomes unstable. Atherosclerosis is not just a slow buildup of material in the artery wall. It is a living process, shaped by inflammation, vessel stress, and the biology of the plaque itself. That matters because a plaque does not have to be huge to be dangerous. A vulnerable plaque can rupture, expose its contents, and trigger platelet activation on the vessel surface. The body sees that exposed material as damage and rushes to repair it. In the heart, that repair can become the problem. Think of it like a blister with a thin covering. While the skin holds, the injury looks minor. The moment it tears, the contents spill out, and the clotting response begins. What seemed silent is now active, and the timeline becomes short. This is why positive remodeling is so important. As plaque grows, the artery can expand outward at the same time, preserving the inner opening and hiding the disease from obvious symptoms. The vessel is not necessarily closing in a simple straight line. It is changing shape around the problem. That makes the artery look more forgiving than it really is. Blood can still move through, the person can still feel fine, but the wall itself may already be loaded with lipid, inflammation, and instability. The danger is not only the size of the narrowing, it is the structure of the plaque beneath the surface. And that is the first contradiction this episode has to break apart. A person can have a lot of plaque and no obvious pain. Another person can have a smaller plaque and still experience a sudden event. What changes is not just the quantity, it is the phenotype of the plaque and whether it is ready to break. Plaque rupture is not random chaos. It has a biology. The cap over the plaque can become fragile, the inflammatory environment can intensify, and the exposed material can trigger a thrombus that builds fast enough to block flow. That is how a silent process turns into an emergency. The part most people never appreciate is that the event often feels sudden because the rupture is sudden. The disease was not sudden, the final step was. That distinction matters. It changes how you look at a healthy-looking person who ends up in crisis. It also changes how you look at imaging. Coronary CT angiography can reveal plaque features that are not obvious from symptoms alone, and positive remodeling is now recognized as a high-risk feature that cardiac imaging should pay attention to. That means the artery can be telling a deeper story than the pulse, the workout, or the fact that the person feels fine. So the real question is not whether plaque is present. The real question is what kind of plaque it is, how the artery is adapting around it, and whether the surface is stable enough to hold. Everything else in this episode flows from that one hidden variable. The problem is not only that plaque exists. The problem is that your heart can be under strain long before the pain starts. Ischemia is the moment the oxygen supply can no longer keep up with the heart's demand. That mismatch can happen quietly at first, then reveal itself under stress. This is why someone can feel fine at rest and struggle during exertion. A narrowed artery may deliver enough blood when the body is calm, but not enough when the heart rate rises and the muscle needs more oxygen. The system looks stable until the load increases. That is the hidden logic behind stable angina. The symptoms often appear with walking, climbing stairs, cold exposure, emotional stress, or a heavy meal, then ease when the demand drops. The body is telling you that the reserve is shrinking, but even that does not explain why some people seem protected longer than others. The answer is collateral circulation. The heart can grow tiny detour vessels around a chronic blockage, creating backup routes that reduce ischemia and preserve function. Those detours are not magic. They are adaptation. Think of them like side streets built around a traffic jam. The main road is still damaged. The city just learned another way to move blood through the network. That can delay symptoms and buy time, but it does not remove the underlying disease. This creates a dangerous illusion. A person may think, I can still exercise, so my arteries must be fine. Not necessarily. The body may simply have found a temporary workaround. Workarounds are not the same thing as safety. The deeper point is that the heart does not fail all at once. It fails when reserve is exhausted, when supply cannot meet demand, or when the system is asked to do more than it can handle. That is why exertion can expose what rest hides. And that is the contradiction this chapter leaves behind. The same body that protects you by adapting can also conceal how close it is to running out of margin. The story changed once imaging got better. For a long time, medicine could only guess at risk from symptoms and blood markers. That was useful, but incomplete. The artery wall could still be hiding a larger story. That is why coronary artery calcium scoring became important. CAC does not tell you everything, but it does tell you whether atherosclerosis has already left a visible footprint. In primary prevention, guideline-directed use of CAC can refine risk and change how clinicians think about people who look healthy on the surface. A score of 0 is reassuring in the right context. It lowers the chance that calcified plaque is already driving risk, but a score above 0 means the process is not hypothetical anymore. It is documented. The limitation is that calcium is only one part of the plaque story. Some plaque is soft, non-calcified, and harder to detect with calcium scoring alone. That means a person can still have biologically important disease even if the calcium picture looks modest. Coronary CT angiography goes deeper. It can reveal stenosis, plaque burden, and high-risk plaque features that extend beyond what a calcium scan shows. That is where the evidence becomes more interesting, because the artery is not just a tube. It is a structure with layers, composition, and behavior. The best analogy is not a clogged hose. It is a wall that can look stable from a distance while the inside of the wall is changing. A scan can expose those hidden changes before they become a crisis. That is the missing piece many people never think about. What matters most is that this changes the timeline. The body can compensate for a long time. Symptoms can stay quiet. Blood work can stay ordinary. but the artery wall may already be showing the first evidence of disease. That is why imaging is such a turning point. It makes the invisible visible. And once the invisible becomes visible, the question is no longer whether risk exists. The question becomes how far the biology has already moved. The heart does not always scream before it fails. Sometimes it whispers. In women especially, the warning signs can be easy to dismiss because they do not always look like the classic movie version of a heart attack. That can mean unusual fatigue, shortness of breath, nausea, upper back pressure, jaw discomfort, or a feeling that something is simply wrong. Those symptoms may arrive quietly, build gradually, or be mistaken for stress, indigestion, or a bad night of sleep. That is why silent ischemia is so dangerous. A person may not have crushing chest pain and still be in real trouble. The body can keep the signals subtle while the risk keeps rising. One of the most overlooked clues is fatigue. Not ordinary tiredness, unusual, unexplained exhaustion that does not match the person's activity level. Some women describe it as feeling too tired to do simple tasks or feeling drained for no clear reason. That is not nothing. It is information. Shortness of breath matters just as much. It can appear with or without chest discomfort, and in some people it may be the main symptom. When the heart cannot keep up with demand, breathing may become the first thing the body notices. Nausea, indigestion, and upper abdominal discomfort also belong in this story. Those symptoms often get blamed on food, anxiety, or a virus. Sometimes that is true, sometimes it is not. The pattern is what matters. This is where imaging becomes so valuable. A coronary CT angiography scan can show plaque burden and help reveal disease that symptoms and routine tests may miss. More detailed plaque analysis can add another layer of risk information, because not all plaque behaves the same way. That means the visible story can be different from the felt story. A person can look stable on the outside, yet already carry the anatomy of risk underneath. The body does not always label the danger in the language people expect. So the lesson here is not to panic over every symptom. It is to stop assuming that a quiet presentation means a harmless one. Heart disease can be silent, subtle, or mislabeled for a long time before it becomes obvious. The biggest mistake is thinking heart disease always gives you a dramatic warning. Sometimes it does, but often the first clues are quieter. Chest discomfort that comes and goes, shortness of breath, unusual fatigue, nausea, lightheadedness, or pain that spreads to the arm, back, neck, jaw, or stomach. If you wait for the movie version, you can miss the real one. That is why silence is such a dangerous signal in this story. A person can feel stable and still be carrying risk. The body may be compensating, the plaque may be hiding, and the warning signs may be too easy to dismiss. By the time the pattern becomes obvious, the moment may already be urgent. Imaging helps separate reassurance from illusion. A CAC score of 0 can be reassuring in the right prevention context, but it does not erase the need to understand the broader clinical picture. Coronary CT angiography can go deeper by showing plaque and plaque features that calcium scoring alone may not fully capture. That is why the wall matters as much as the blood. And when an acute coronary syndrome is happening, the response changes from observation to emergency care. The 2025 ACC to AHA-ACS guidance emphasizes rapid, guideline-directed treatment, including PCI when appropriate, along with antiplatelet therapy and other hospital-based measures. That is not a promise of safety. It is a reminder of how serious the event is once the system crosses that line. The deeper lesson is the one the episode has been building toward from the beginning. A healthy-looking body can hide a dangerous process. A strong workout routine can coexist with vulnerable plaque. Normal blood tests can miss the wall itself. And a person can feel fine right up until the moment the margin disappears. So the real takeaway is not fear, it is clarity. Heart disease is often a process of quiet adaptation, hidden instability, and sudden transition. Once you understand that, you stop trusting silence as proof of safety. You start reading the signs with a sharper lens. Your body has been signaling this for longer than you think. Now you know how to see it. If this changed how you think about your body, subscribe and explore the rest of the series in the description below.